So it's case presentations, and how what the format is that we've got a panel of esteemed clinicians who are representing the entire continents that they live in. So it's a huge weight that they have on their shoulders. So what we're going to present to them is a series of cases that we've chosen that pick up on issues that are relevant, that particularly don't fit in the category that go within a guideline. And we all know those patients that just fit between all those little nice tables that we have in a guideline. So we will go through some of those cases, and in between we'll pause and we'll get some reflections from each of our colleagues. So I just want to go through, so we want to, if you can just introduce yourself.
Hi, my name's Jason Brophy. I'm a pediatric infectious disease specialist at the Children's Hospital in Ottawa, Canada. So I guess I represent the Americas.
No, we said the entire Americas. We decided.
I don't. I'll leave that as it is.
Hello, my name is Henriette Xray. I'm a pediatrician and based in Amsterdam in the Emma Children's Hospital Academical Medical Center. And so I think Europe, yeah.
I'm Tawitia Sujarilak, pediatric infectious disease specialist from Chiang Mai University Hospital, Chiang Mai, Thailand, and I'm representative of Asia.
Hi, my name is Grace McHugh. I'm a physician with an interest in adolescent HIV medicine and specifically clinical research in that area. I work in Zimbabwe, so I guess I'm representing Africa.
Yay!
Hi, my name's Gareth Tudor-Williams. I'm a pediatrician in London. And so without further ado, we're going to start with this child who, this is all based on real experience of children arriving from Africa. And I thought this was particularly useful to dissect out some of the issues that may come across in different settings in the world. So this family recently arrived from Nigeria, and the mum had tested positive on new patient screening when she enrolled with her general practitioner in primary care. And she'd never been tested before. She was clinically well, and if you were going to categorize her, she was WHO stage 1. And so obviously for the panel, I'd just like to stop at this moment and ask you just immediately where would you go with this? So can I start with Henriette?
I'm very curious if this mother, how many children she has, and maybe what the test results of these children are, and possibly there's also a partner.
Absolutely, and maybe Tawitia from Thailand?
Yeah, I would like to ask this question too, and also I may ask about the mom's test positive at the first time, but she never had exposed to kind of ART such as for PMT-CT or anything else.
That's what we understood. So it prompted screening of her 2 children, and there was a 5-year-old boy who turned out to be HIV infected, and there was a younger sister who was not infected. And the history of the little boy was a bit worrying. So he'd had jaundice as a neonate. He'd apparently received some kind of blood transfusion. We weren't clear if that was an exchange transfusion. Had otherwise apparently had no hospital admissions, wasn't taking any medication, and there was no relevant family history disclosed. So on examination, and including some of the very initial findings, this boy was failing to thrive spectacularly. So a BMI of 14, his weight was 13.9 kilos, you can see the data. He was also developmentally delayed, he had delayed bone age, there was generalized lymphadenopathy, and then worryingly there was a recent clavicular fracture and an unexplained linear lesion on the scalp and on his legs. The father we didn't get to meet at the first appointment, so there were these concerns over domestic violence that we were very worried about. So in your setting, can I ask Jason, in Canada, where would you go with this?
For a newly positive child, we would do our full screening panel of investigations. We would want a CD4 viral load, baseline genotyping. We would want a full blood count, renal function, and liver function. We would want responses to vaccinations and take a good vaccination history. We would want to do TB screening, in particular in this child with failure to thrive. And we would do a urinalysis looking for any renal dysfunction as well. And then in terms of the potential for domestic violence and recent bone fracture, we would have a good social history taken by the physician and or the social worker.
Thank you very much. So Grace, in your setting?
So in our setting, we would want to do all of those things too. However, we wouldn't have the resources to do such investigations. We might be able to do a full blood count, a U&E, and potentially liver function tests. But we would proceed to initiate on antiretroviral treatment without knowing his CD4 or indeed a viral load at baseline, which would not be...
On the basis of WHO guidance.
Exactly.
And absolutely.
Yeah. As regard, the mum and the child presented to a primary care setting, so this would be decentralised care in our setting, which would be nurse-initiated care, and such nurses wouldn't really have a lot of social service backup. So although they might recognise that the child would be living in a vulnerable household, there might not be a lot of input that they could offer as regards that.
Yep. So this is the situation. We have a child who's got a viral load, as you can see, 34,000, CD4 count 580, apparently naive to antiretrovirals. We know now that he's HLA-B5701 negative. I'm sure that's not something Grace would be checking. You can see that the rest, no real concerns in the rest of that history. Well, I think Grace has already answered what she would do. Would you get on and treat this child?
It's important in our setting here that a child with a severe failure to thrive, I think, and coughing, is that we would like to investigate first TB for presumptive TB infection.
Sure.
That's what I would suggest.
Anything else?
And if it's, depending the test, of course, and also would like to have an imaging of the child, the Xray of the chest.
Okay. Tavitya, is there anything that you would add before starting treatment in Southeast Asia?
In terms of the social support, such as the kind of find the caregivers of this child, maybe because this child is too young to take care of themselves. So if I would like to start ART, I will find out the primary caregivers and discuss with them about this HIV status of the child.
Okay. So we were a bit surprised because we did baseline resistance testing to discover that this child had very extensive NRTI and some NNRTI resistance. And you can see that the Stanford prediction was of a number of agents that were not going to be very useful first line. And so no significant PI resistance. So, this is difficult because you wouldn't have the data if you didn't have access to resistance testing in your setting. Jason, where would you go from here?
So the combinations you can create at that age and size are reasonably restricted. I think you could put together a regimen with a protease inhibitor like a pediatric lopinavir plus pediatric raltegravir plus still throw in some recycled nukes, probably abacavir and lamivudine. I would probably avoid atazanavir because you need liquid boosting. Or liquid ritonavir boosting, which never goes down well. I'd probably start with Kalecha for that reason.
Okay. Grace, just supposedly this child maybe have somehow got access to a research program, you know the resistance data. How would you treat this child?
If I'm very honest, we just would not know the resistance pattern on this child. And what would probably happen is he would have been started on 2 NRTIs and an NRTI, and we would have had to wait for him to fail that treatment.
Fail clinically?
Yeah.
Or simply not respond?
Exactly.
Yeah.
Before we would then think, and then our next thing would be to move on to a lopinavir-based regimen, given his weight. Yeah. We would not have access to, kind of ritonavir boost, separate ritonavir agents in Zimbabwe.
Uh-huh.
Yeah.
So it obviously prompted a long conversation with the mother, who was able to admit that she and her child were already on treatment before they came, and she feared to tell her husband. I think there was a real issue around the way he had been treating the family already. She was worried about being abandoned. She was giving the ARVs to herself and to her child in secret, and so she also had extensive NRTI and NNRTI resistance. So the social situation, we really haven't addressed the safeguarding issues, but now you've got the added complication of a father who we don't know his status. We really want to try, and the mother is clear that she wants to try and stay on board with this man. How are you going to manage that? Henriette?
I think it's definitely necessary to talk to him and tell him that this child is now positive tested, so that you don't go back in the past. And we had a similar case in our hospital, and we presumed that the infection was now, and so it was a relief, in fact, for the mother. And it went well, so I would do it again like this. There's another.
So you get the father to test.
Yeah.
Separately, yeah.
Yeah.
Okay, Tavitya.
Yeah, for me, I would encourage the mom to tell her HIV status to other family members, at least her husband, because I think if the HIV is the secret in their family, this will happen again and again, because she has no other support in the family. So I, as a physician, I may not disclose her HIV status to her husband directly, but I would encourage the mom to tell her HIV status to his husband.
So I'm hoping that you guys in the audience are thinking how you would manage this, because actually I was hugely impressed. This case was brought to us by Dr. Julia Kenny, who many people in the room may know, who was involved in the CHAPAS studies and lots of HIV work, and now working at the Evelina Children's Hospital in London. And she brought it to our pediatric virtual clinic, and this is something that we've been running for a number of years, led by Caroline Foster and several of us who are interested in HIV resistance. And we felt that it was really important to engineer a way to get this father tested in a way that would allow the conversation to happen. I mean, I think, Tavitya, if we had encourage this mother to disclose without giving her some way of dealing with this, it might have ended very badly. And so our colleagues used the evidence that the child was HIV infected. Because he'd had the blood transfusion in the neonatal or in the newborn period, we were able to say it's quite possible that the HIV came from there, but this is a eminently treatable virus, really important that we test all the members of the family. So why don't you and your wife get tested at the same time? And indeed, that's what they did, and he turned out to be HIV uninfected. His wife turned out to be HIV infected. But he was there for her. He was then able, and the fractured clavicle turned out to have a perfectly good reason, and the safeguarding issues had been dealt with, and everybody was happy with that. And so they are now coming to clinic. He's supporting the family. We started the child on cotrimoxazole to see whether the child could swallow pills, and then using an estimated expected weight of 15 kilos, actually went down Jason's route with raltegravir, remembering the bioequivalence is not the same for all of the different formulations. We were offering tenofovir because, of course, there's no TAF at this age, and lamivudine to maintain that M184 plus a boosted PI. And the only thing I would add is, of course, this child's got severe neurodevelopmental compromise, and we wanted to think about the central nervous system. And you can see there that on this kind of assessment, which may have its flaws, raltegravir at least is going to be helpful within the central nervous system. But it's worth remembering that tenofovir is not a great drug for the central nervous system, and these are issues that we think about. Anyway, I'd like to hand over now to my friend Mo. Thank you very much.